A good afternoon to you all. I am Helen Biorenda-Dije, the leader of the African chapter for ISoP, and I'm happy to facilitate the following two presentations from the Africa region. Thank you to each of you for being here with us today. We hope that all of you and your families are safe during this complex time in the middle of the COVID pandemic. And on behalf of the International Society of Pharmacovigilance, we are very pleased to welcome you all to the second edition of the ISoP Patient Safety Day event that will be held in two modes. One for today, that is September the 16th, and also tomorrow, September 17th. The World Health Organization established the Patient Safety Day to increase public engagement in healthcare safety and to promote global action to prevent and reduce avoidable harm in healthcare. This year's World Health Organization event is promoting safe maternal and newborn care. ISoP supports this idea to promote patient safety worldwide, especially in medication use. And we included more relevant topics around medication safety for promoting global action to prevent and to reduce medication risks around maternal and child care. So please join us in our different sessions. And starting now with our president, Mira Harrison, she will address in a few words to all of you. Please listen in. Thank you.
Welcome to this webinar organised by the International Society of Pharmacovigilance for World Patient Safety Day 2021. My name is Mira Harrison-Woolrich and I'm the president of ISoP. Our professional society is a worldwide organisation with several hundred members working in pharmacovigilance. Our aim is to promote the safe use of pharmaceutical products in all countries. World Patient Safety Day was established by the WHO in 2019 and it's marked on the 17th of September each year. It's an important day for ISoP because it promotes patient safety as a global public health priority. Every year, millions of patients die from an adverse event, and many of these are related to pharmaceutical products. This year, with the continuing COVID-19 pandemic, global awareness of medicines and vaccine safety has been extremely high. The everyday work of those of us in pharmacovigilance has made international headlines on a regular basis. ISoP members work in very many different sectors, from drug development, medicines regulation, academia, to pharmaceutical companies. And for all of us, the end point of our work is patient safety. Every issue analysed and discussed is meaningless unless we consider how it impacts on the patient themselves using medicines in their own environment. Drug safety issues also affect the family and friends, including children and carers of patients using medicines. I'd encourage you to think about this broader holistic approach as you watch this webinar today. The WHO theme for World Patient Safety Day this year is maternal and newborn health. So please remember this because it is especially relevant. Wherever you are in the world, I hope you enjoy this webinar that we've made for World Patient Safety Day. We hope you find it interesting and informative. If you work in pharmacovigilance and you'd like to join ISoP, please have a look at our website, isoponline.org, and consider making a membership application. We would welcome you in joining our professional society so we can all work together towards improving patient safety worldwide.
Yeah, thank you for your attention. And I would like to invite you to show your participation in the social media campaign using the hashtag ISoPOnline, PSD at 2021, and ISoP, hashtag ISoP medication safety, hashtag ISoP med era, MED-ERR, and hashtag World Patient Safety Day, and publishing your pictures or ideas about medication safety topics. That will be very interesting. And now let me introduce to you Dr. Lubna Alj, who will make her presentation entitled Immunization Errors Related to COVID-19 Vaccines in Morocco, Surveillance and Risk Minimization Actions. Dr. Lubna Alj is a pharmacist, specialist in epidemiology in public health. She has an experience of 19 years at the Center Anti-Poison and Pharmacovigilance in Morocco in WHO, the Collaboration Center for Strengthening Pharmacovigilance Practices, and she's involved in the whole process of pharmacovigilance from detection to action. In 2006, she put in place the Medication Errors Management Unit at the Moroccan Pharmacovigilance Center, and she contributed to the WHO guideline on reporting and learning systems for medication errors, the role of pharmacovigilance centers. And Lubna participates in trainings regarding pharmacovigilance and medication errors at both the national and international levels. She's an active member of the Medication Errors Special Interest Group of the International Society of Pharmacovigilance and the WHO Global Patient Safety Network. She's an author and co-author of several national and international publications regarding medication errors and preventable adverse drug reactions. And in the context of the COVID-19 pandemic, she sought to be trained on pharmacovigilance of vaccines, and she completed the WHO e-learning course on vaccine safety basics and investigation of adverse events following immunization. She's a member of the International Society of Pharmacovigilance and the Moroccan Society of Pharmacovigilance. We invite you to participate actively in this session. So if you have any questions, please put them in the chat pod on the left, and we'll be responding to some of them according to our schedule, and the rest of them will be collected, and a Q&A list will be published on our website in the coming days. That is on www.isoponline.org. So without any further ado, please give a warm welcome to Dr. Lubna Alj.
I am delighted to participate to the patient safety event organized by the International Society of Pharmacovigilance. Now I will share with you my presentation about immunization errors related to COVID-19 vaccines in Morocco, surveillance and risk minimization actions. After a brief introduction, I will display the aim and the methods of the study regarding immunization errors. Then I will present the results and the findings of our study and discussion related to it. And before to conclude, I will share with you some take-home messages. COVID-19 has affected millions of people and led to burden to healthcare systems as well as economies throughout the world. Currently, there is no decisive therapy for COVID-19 or related complications. The only hope to mitigate this pandemic is through vaccines. The COVID-19 vaccines are being developed rapidly compared to traditional vaccines, but without cutting back on testing and safety measures. These vaccines are approved via emergency use authorization worldwide. Therefore, monitoring the COVID-19 vaccine safety profile by collecting and analyzing adverse events following immunization is fundamental. So, according to the World Health Organization, adverse events following immunization are classified into 5 categories: vaccine product-related reaction, vaccine quality defect-related reaction, immunization error-related reaction, immunization anxiety-related reaction, and coincidental events. So what are the characteristics of immunization errors? Immunization errors could occur during the storage, preparation, administration, or the vaccine use process. They are considered as preventable. Immunization errors may or may not cause harm to the vaccinated person. These reactions may sometimes lead to a cluster of events associated with immunization. When they occur, immunization error-related reactions should be investigated to minimize these adverse event recurrence. Such situations could compromise vaccine or vaccination campaign, particularly if they lead to serious harm to the patient. So the aim of our study is to describe the profile of immunization error related to COVID-19 vaccine reported to the Moroccan Pharmacovigilance Center, and also to describe risk minimization actions that was taken proactively and reactively to prevent their occurrence. Then we carried out a prospective analysis of immunization errors reported to our National Pharmacovigilance Center as part of the surveillance of AE5s related to COVID-19 vaccine from 28 January 2021, which was the date of our national immunization campaign launching, to 31 August. Immunization errors were reported through the AE5 reporting form, and the Morocco put in place a reporting form for this vaccine, and also through the electronic line listing that was developed on the basis of the Morocco reporting form. Immunization errors were also gathered through two hotlines that were dedicated for healthcare professionals, and another one was dedicated for patients. Also, we have, for our data source, we have the online platform that was dedicated for patients only. These hotlines and this platform were set up by the Moroccan Ministry of Health as part of the national immunization campaign to facilitate adverse event following immunization reporting and to respond timely to healthcare professionals and patients. All reported adverse events following immunization were entered into VigiFlow, including immunization errors. Okay, our study variables are, these immunization errors were classified according to the stage of the vaccine use process, according to the type of immunization errors, and we use the MEDRA terminology for that purpose, according also to the reporter's profile, whether it was healthcare professional or patient, and also according to the vaccines available in Morocco, in our country. So at the early stage, of the national campaign, we had Covishield and Verocell, and later on July, we had Jensen and Community Vaccine. Investigations were conducted to identify causes and contributing factors that led to immunization errors in the view of implementing risk minimization actions. These investigations were conducted using the WHO AE5 investigation form that was adapted for COVID-19 vaccines. And the quantitative variables that we had were expressed with number and percentage. And this is regarding our data analysis. Now I will display the results of our study. So as of 31 August 2021, the total number of immunization errors reported reported to the Moroccan Pharmacovigilance Center was 60, which represents 0.252% of the total AFIs that were reported to the Pharmacovigilance Center. The incidence of these immunization errors was 4 cases per million doses of vaccine administered. And among these immunization errors, only 4 led to harm to the patient. Immunization errors occurred at the administration stage of the vaccine use process in 55 cases and in the preparation stage in 5 cases. In fact, 5 vaccinators had accidental projection of vaccine droplets in their eyes while they were expelling air bubble in prefilled syringes. So 2 of them developed ophthalmic adverse reactions and the outcome was favorable. Regarding the type of immunization errors, 25 25 patients were administered the wrong vaccine at the second dose. And among these cases, 20 were belonging to the same cluster. Regarding the type of administration error of inappropriate schedule of vaccine administration, in 9 cases, the patient received 2 doses of the vaccine during the same vaccination session. So there was duplication of the vaccine in the same session. And 13 cases, the patients received the second dose of the vaccine before the interval that is recommended between 2 doses. And at the time of our study in Morocco, COVID-19 vaccines were contraindicated in pregnancy and lactation. Then 6 women were accidentally exposed to the vaccine during pregnancy first trimester. 1 of them had abortion 1 month later, and 2 women were administered the vaccine during breastfeeding. All these immunization errors have been reported by healthcare professionals, and some of them were also spread across electronic media, as you see in this photo. And only AstraZeneca and Sinopharm vaccines were involved in immunization errors in our study. So in general, investigations performed revealed that organizational issues were the main causes behind immunization errors happening, such as staff shortage at the vaccination site, which led to cumulative tasks for the immunization team, or non-compliance with the one-way pedestrian flow by the population. Also, the use of 2 vaccines in the same vaccination site. In fact, at the early stage of the campaign, this safeguard was applied, but in some vaccination sites, they were trained to use both of them, and this led to administration of the wrong vaccine in some cases. Immunization errors were also due to non-compliance with procedures, and in some cases, healthcare professionals omitted to ask and to seek for contraindications such as pregnancy and lactation in women. So, as I already said, we had a cluster of 20 cases that were belonging to the same vaccination site and the same day. And in these cases, the patient received the Covishield vaccine at the first dose and the Verocell vaccine at the second one. In fact, the investigation revealed that the cluster was due to staff shortage. So 1 nurse only was managing the vaccination session this day, and the 2 vaccines were available in the vaccination site. So the nurse was trained to switch from a vaccine to another, depending on the population that was visiting the vaccination site. So that day, the supportive staff, who is responsible for managing the patient registration and the patient path, was late. So then another staff, which was not familiar with these tasks, was designated to help this nurse. So the patients were split in two groups, those that should have the second dose of Sinopharm and those that should get the AstraZeneca one. So the new staff started with the Sinopharm group to have their second dose, but he forgot to inform the nurse that he switched to the AstraZeneca vaccine for the second group. So this group had the vaccine Sinopharm by error. So regarding these immunization errors that I shared with you and that were reported to the Moroccan Pharmacovigilance Center, reactive risk minimization actions were implemented in collaboration with our national committee, and poster was designed to remind proactive actions that reduce the risk of errors, such as the importance of seeking for contraindications or reasons that would affect patient suitability for vaccination, and the importance of applying best practices for immunization session management. The poster also provided actions that to take after an error occurring according to the scenario of each incident that we received. So the results of our study showed a low incidence of immunization error in Morocco that were related to COVID-19 vaccines. And these immunization errors were not associated with serious harm. Moreover, only 4 cases led to harm to the patient. This could be explained by the setup of preventive strategies to minimize the risk of immunization error occurrence, including proactive measures prior to the launching of the immunization campaign, proactive measures during the campaign, and reactive measures that we have just. So, in fact, our Ministry of Health created a scientific committee for the development of strategies for COVID-19 vaccination, and including risk minimization actions to reduce the likelihood of immunization error occurrence. So this committee was composed of multidisciplinary experts from in Morocco, as well as pharmacovigilance experts. So as part of the developed strategies and prior to the launching of the immunization campaign, training sessions were organized for healthcare professionals involved in the campaign on situations that are at higher risk to errors in the vaccine use process. So regarding the storage, the training focused on the importance of the maintaining of the cold chain, the importance to follow manufacturers' storage instructions, and to follow guidelines for temperature monitoring. Also, the training raised the awareness of immunization team to review the refrigerated and frozen vaccine and remove any expired product. It was also recommended to separate vaccines in storage and ensure that no other substances and or injectable drugs are stored in the immunization center. Indeed, shared learning from ISMP and the CDC have raised awareness about errors involving selection of the wrong products that have occurred and led to inadvertent administration of other drugs instead of the vaccines, such as insulin, neuromuscular blocking agent, or monoclonal antibodies. Now, as part of the preparation of the vaccine, a standard process was developed and followed for dose preparation of each vaccine product that is available in our country. And regarding the prefilled syringes, they should be labeled with the vaccine name, the volume, the lot number, and the beyond use date and time. So these information are important and they should figure on the label of the syringe. Regarding the administration of the vaccine, the training highlights the importance of the use of a checklist in order to identify vaccination contraindications or precautions. The immunization team should also conduct visual check of the volume in the syringes to avoid administration of low doses or extra dose of the vaccine. The labeling of syringes should also be verified to ensure that the right vaccine was selected and we are not using a vaccine that is beyond the use date or the beyond use time. Regarding the administration of the dose 2 of the vaccine, the staff should ask the patient about the vaccine that he was administered at dose 1 and the receive date of dose 1 in order to check the interval between the two doses. And if the patient experiences allergic reactions following the dose 1, that could contraindicate the second dose. So the staff was encouraged to report immunization errors when they occur to the Pharmacovigilance Center through all the means that were put in place for that purpose. As part of the preventive strategies, organized training also provides sessions about the workflow processes of an immunization session. And this was organized for healthcare professionals as was that were implicated in the immunization session, but also to the supportive staff that was helping them in the session. The committee also recommended the exclusive use of one type of vaccine in the same vaccination site. And the Ministry of Health planned to dedicate refrigerators and freezers for COVID-19 vaccine storage only. So this was key to avoid errors that selections that could be in some cases fatal if, for example, we have the neuromuscular blocking agent that given instead of the vaccine. So this was a very important proactive action that was taken by our Ministry of Health to avoid these type of errors. And for managing the patient's appointments to be vaccinated and for patient registration, an information technology system was developed to collect personal and clinical information about people that were vaccinated in our country. Now, during the campaign, healthcare professionals were informed every time there is something new or a vaccine new or new formulation, they were informed about that. So we have the introduction of a new formulation in or Sinopharm vaccine in our country. First, we had only one dose in the vial, but later on we have 2 doses in the same vial. So a letter that you see in the slide was sent to healthcare professionals in order to prevent extra doses to patients as well as the wastage of the vaccine. And we all know that we have vaccines are not available in all countries, so we should not have waste of these vaccines. Okay. in our campaign also, we had introduction of new vaccines, such as later on July, such as the Jensen Vaccine, and we also advise our healthcare professional about the introduction of this vaccine and the fact that this vaccine needs one-shot vaccine only. And when the community vaccine was introduced in Morocco, training and documentation about the following instructions and the distribution procedures were provided to our healthcare professionals in the vaccination site, and the video was recorded to show them step by step the process of these two important stages of the community preparation. And for sites administering more than one COVID-19 vaccine product, it was recommended to set up separate preparation and administration areas for each vaccine to avoid product and dose mix-ups. It was also recommended to put signatures to identify each area that should be clearly visible for the immunization staff as well as for patients. And during the campaign, we had continuous training of healthcare professionals about all these proactive risk minimization actions that was put in place before and during the campaign. And also we put in place a training course about immunization error. So the definition of immunization error, characteristics, situations that are at high risk to immunization errors in the vaccine use process, and strategies for safe immunization with COVID-19 vaccine. So before to conclude, here are my take-home messages to reduce or eliminate the risk of errors related to COVID-19 vaccine. First, putting in place preventive and reactive strategies and delivering training for healthcare professionals and supportive staff about these strategies, sharing learning at national but also international level. In fact, the ISoP Canada and CDC bulletins and publications regarding COVID-19 vaccine errors played a major role to design proactive and reactive measures by countries. And continuously adjusting and improving the workflow is also of great importance. So in conclusion, the proper planning and implementation of proactive strategies for safe COVID-19 vaccination is fundamental to prevent immunization errors related reactions. When it occurs, immunization errors should be reported to the Pharmacovigilance Center, and this investigation should be conducted to identify causes and contributing factors in the view of implementing risk minimization actions in order to prevent error, occurrence, and recurrence. And sharing immunization errors experience with countries will support future learning and error prevention to achieve a successful COVID-19 immunization campaign at national and international levels. Thank you for your attention.
Okay, thank you so much, Dr. Lubna. Very interesting topics to discuss in the session, in the second edition of our Patient Safety Day. Indeed, last year, we had more than 30,000 people joining us by synchronic joining us all together, and we had recorded sessions, and we hope to continue with this successful promotion of patient medication safety every year. Now, let me introduce to you Dr. Ronald Chakova, who will make his presentation entitled Patient Safety Day 2021 about medication safety officers in healthcare in low and middle income countries. Dr. Ronald Chakova is a pharmacist and part of the Department of Pharmacology and Therapeutics, College of Health Sciences in Makerere University, and he's promoting high quality research into the occurrence of adverse drug reactions, medication errors, and other drug-related problems in low and middle-income countries. He's interested in promoting pharmacovigilance and the scale-up of pharmacobiological methods to understand medication use and safety in low and middle-income settings where such data is limited. The documentation of medication-related harms in these settings is expected to foster improved medication safety practices. Thank you very much, Doctor, for joining us. You are welcome to make your presentation. Dr. Chakova.
Good afternoon, ladies and gentlemen. My name is Ronald Chakova from Makerere University. I am a pharmacist with additional training in clinical epidemiology and biostatistics, and I'm very passionate about pharmacovigilance. In this presentation, I'm going to talk about healthcare as a risk factor for patient harm. And then I will describe the medication use process and as it relates to patient harm. I will then delve into the details of the new role in this setting as well globally, which is the role or the position of the medication safety officer. And then I'll talk about the medication use pyramid and how the medication use officer can utilize it to promote medication safety. I will also talk about the responsibilities of the medication safety officer, or MSO, and as well highlight the key performance indicators in measuring medication safety. Then I'll wind up with a case study on the role of pharmacovigilance in measuring medication errors and how to prevent them in order to promote medication safety. So this presentation is arguing a case for the introduction of medication safety officers as key persons in healthcare in low and middle income countries, especially with regard to promoting medication safety. So healthcare is indeed cherished because it's promoted modern medicine. However, we should bear in mind the fact that with all the good intentions that come with healthcare is the risk associated with patient harm, which is not often always intended. Worldwide, there are about 5 patients who die every minute because of unsafe healthcare. In low and middle income countries alone, 2.6 million people die as a result of unsafe healthcare in at least every single year. Medication errors which ideally is the epitome of patient harm, can lead to adverse drug events. And 1 to 2.5% of cases usually experience these adverse events. A medication error is defined as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, the patient, or the consumer. And an adverse event is defined as an injury caused by medical intervention and is usually associated, as it were, with the use of medicines. Here we attempt to describe what is already known, which is, of course, the medication use process, and how patient safety comes into play as we look at the different stages of medication use. So take, for instance, if we start with procurement, and then we move on to, after the medicines have been received, they need to be stored. So there are mistakes that can occur during that phase of drug handling. And especially if we look at the cold chain, for instance, when we deal with vaccines, we know that sometimes those processes may not be adequately followed. So errors can arise, which could lead to the degradation of the medicines. And then we could have errors that arise as the medicines are prescribed for the patient. So sometimes it could be a prescription of an overdose or an underdose or a missed, in the writing of the prescription, we could miss out the appropriate method that should be used. So if the drug for it should be administered orally, someone could accidentally write by injection. Or if the drug is supposed to be administered once, they might prescribe twice or thrice, which could lead to overdose and eventual harm. So, and sometimes the prescription could be written well, but the person who transcribes the information ends up doing it the wrong way. And so medication errors can occur during dispensing, during drug administration, and so on and so forth. So these errors, as it were, could result into adverse drug events. So the medication safety officer would be a handy person to take charge of the responsibilities of ensuring that patients receive care and that they receive it in a safe environment. So the medication safety officer ideally should be a dedicated position. Why? Because healthcare professionals, especially in low and middle income countries, tend to get overwhelmed with patients because of the very low healthcare professional to patient ratio. And so they do not have enough time to evaluate every single step that they take as they deliver care to the patients. And so this dedicated role of the medication safety officer will be responsible for leading a health facilities medication safety program. So this person is fully focused on the cause of promoting patient safety. So the role of medication safety officer is relatively new globally. For instance, it was first published in the US in 2013 and in 2016 in the United Kingdom, and has been required in UK hospitals since 2014. So the medication safety officer will be focused on reducing the harm associated with the use or the receipt of healthcare. The literature says that the MSO, or the Medication Safety Officer, if given an opportunity to work 20 hours a week, can actually improve the safety score of any facility or an organization by up to 233%. And this was found in a study that was conducted over a decade duration. So the MSO's mission is primarily to prevent patient harm. And this role could be played by a pharmacist, a physician, or a nurse. Traditionally, pharmacists have been favored because they primarily train with focus on medication use. Of course, among other things, they focus on drugs. And so they would have that extra edge, but that doesn't preclude the involvement of other healthcare professionals. So a medication safety pyramid has been proposed or postulated. And it is a known fact that everything else that promotes a safe culture actually promotes patient safety. So when you look at this pyramid, you will notice that having a safe culture ideally is at the base. It is the foundation. So you cannot speak about any other drive or any other program to promote patient safety if there is no safe culture. So this safe culture should be exhibited by the healthcare professionals or the health workers. It should be exhibited by the patients who consume the healthcare. And all other systems that work towards ensuring that healthcare is provided to the patient. And so a safe culture is paramount. So any successful medication safety program depends on the presence of a safe culture. So once we've ensured that there's a safe culture, then we can begin to look at the sources of information that the medication safety officer will need in order to promote medication safety. And this information could come from within the organization or from an external source. It could be as well to do with information on standards of care and so on. And then we move on to influence. So the medication safety officer's role, or the MSO, is intended to ensure that there is influence towards practice that is promoting the safety of healthcare. So there should be influence towards promoting patient safety. And this ideally should be done through collaboration. The MSO cannot work entirely on their own. They need the input of others. And then ultimately, at the top of this triangle is patient safety. So medication safety, which is a component of patient safety, is at the top. We want to keep patients safe as they receive medications. And at the end of the day, that's the goal. So there's no point in having a safe culture and all the information, and yet this information and all that goes with it, as well as the influence that is needed, does not ultimately end up in promoting the safety of the clients or our patients. So what are the responsibilities of the MSO? So first of all, this person should be a leader. They should be able to champion and or campaign in a visible way and in an authoritative manner medication safety delivery. So the MSO should play that role visibly. They should be assertive and they should be collaborative. They should be integrative in their approach, but they should be seen to play a key role in promoting medication safety. And then they should exhibit expertise because they are the central people that are responsible for ensuring that medication is taken in a safe way. Then they should advocate for the establishment of medication safety as a core value, both at the individual level as well as at the organizational level. We also see them as facilitators because they're able to leverage scientific strategies to embed safety at the local level as well as the organizational level. And like I mentioned earlier, they need to collaborate. And so they should be able to work across disciplines and to connect across professional silos. And then last but not least, they should be involved in research. Research is critical because it informs decisions. It also informs educational programs, which can be administered both pre-service and in-service. For the case of in-service training, you are basically utilizing evidence to inform decisions. So you are coordinating a process utilizing data. Remember, in the pyramid, we talked about information. So you need information to be able to make good decisions. And one key aspect of the medication safety officer is to operate a successful medication error reporting system, because the data that arise from this system will actually inform practice. And I'll talk a little more about medication error reporting. So I will illustrate some examples of key performance indicators that can be utilized in medication safety. These include the rate of medication errors, the adverse events, and other medication safety practices. And then we also have average overtime in terms of hours, or even where I think hours is the best way to present this per person, because it is known that too much overtime increases the risk of errors. And so if we measure the amount of overtime, we can relate this to what would happen in terms of the increased rates of occurrence of medication errors. Another way of thinking about it is to, in the system setting, reduce the amount of overtime so that ultimately we prevent the occurrence of medication errors. Other indicators to measure include satisfaction with the environment that the healthcare professional works, and also to measure the rate of breakdown of equipment. If you have health related tools, such as, for instance, blood pressure measuring equipment or other electronic equipment, you would want to ensure that they don't break down, because whenever they break down, the risk of occurrence of medication errors increases. And so if you measure the rate of occurrence of equipment breakdown, then you can know what the system is doing or is not doing to promote safer healthcare. And last but not least, employee perception of management in terms of their commitment to ensuring a safe culture. Right. I'll now take a moment to discuss the pharmacovigilance of medication errors and adverse events. I use this case study because it is critical for patient safety, and medication safety officers would ideally play a key role in ensuring that the pharmacovigilance of medication errors and of adverse events is well taken care of, because this is where information is obtained. Remember, we talked about research, we talked about education. That is information, and it needs to be generated. So a good pharmacovigilance system will be able to generate this information through the good role of the MSOs. So what is pharmacovigilance? Pharmacovigilance is the science and activities that relate to the detection, assessment, understanding, and prevention of adverse effects or any other drug-related problems. And medication errors is one example of a medication or drug-related problem. So as it were, we would like to prevent medication errors. So you don't want them to happen and then you start controlling the damage that results, but you want to prevent them from the outset. So a pharmacovigilance system in such an instance would rely a great deal on spontaneous reporting. So there would be spontaneous reporting of medication errors and adverse events by healthcare professionals and by patients. So the medication error reporting process would need a strong professional, someone with the expertise that will ensure that the medication error is analyzed qualitatively before it is reported. So many times we talk about the root cause analysis of medication errors. We want to know what was the cause. And this helps in ensuring that there's quality improvement in the delivery of healthcare. So I'll give a case study of pharmacovigilance in a study that I led a while back, which focused on the evaluation of the disclosure and attitudes to reporting of medication errors in Uganda and by healthcare professionals. So we found that 91% of these healthcare professionals approved the establishment of a national medication error reporting system. And 58% of them endorsed the integration of the medication error reporting system with the existing adverse drug reaction reporting system. So, and we found that 2/3 actually valued the involvement of patients in medication error reporting. It's a known fact that patient engagement is key to safer healthcare. And it is documented that up to 15% of harm is averted when patients are engaged. In this study, 1/5 of the healthcare professionals disclosed that they had ever made potentially harmful medication errors. 2/5 of healthcare professionals had ever observed their colleagues commit medication errors that were potentially harmful. I will now talk about models of safety roles in high-risk industries. So there's need for dedicated safety personnel. And I think I've labored pretty much to introduce the MSO to establish safety-related goals, as well as policies and practices. And there are a number of models within healthcare. For instance, the patient safety officers. So this role is broad. It includes many other aspects of safety, more than just medications. So, but when we talk about a medication safety officer, we are singling out that aspect which focuses on medicines. So the patient safety officer role has existed before the medication safety officer role. And it is documented that and as early as 2004, the PSO, or the patient safety officer, had been inculcated in healthcare in the Western world. And then we have the infection preventionists. These normally operate amongst inpatients, for instance, to prevent infections on central line catheters and to ensure that hospital-acquired infections are kept to a minimum. And then we have the antimicrobial stewards who help to control the prescription of antimicrobials in a hospital setting. So these are models in healthcare that are well known, and the medication safety officer, whom is being advocated for in low and middle income countries, would ideally also play a separate role focusing on the safety of medicines. And then outside of healthcare, we have models for safety officers in the aviation industry, in the law enforcement industry, in laboratories, in fire prevention, and in nuclear power. So the concept is not new. But if the MSO is introduced as a position that is set aside, that is independent of other roles in healthcare, we are well on our way to promoting medication safety in healthcare. As I draw towards the end of this presentation, I would like to bring it to the attention of the audience that even with our best intentions, we are bound to make mistakes. And by we, I mean healthcare professionals. We are bound to make mistakes as healthcare is being delivered to the patients. However, we can reduce the risk of patient harm that results from the delivery of healthcare to our patients. In this short video, we illustrate that even with the best intentions, errors will occur. However, these errors, which could potentially lead to harm, can be minimized.
All of us come here to do good work every day.
We all got into healthcare to do the best we can for patients.
And you have to remember, when those patients come into UHN, they're at their most vulnerable state.
We put our trust in the people within this hospital, and so we expect to get in and out of here in one piece.
But we're human and we make errors.
And it may be because people are working too fast.
Sometimes the supports are not there.
And sometimes even the system that we have actually set up a possibility for humans to make error.
It could be a lighting issue that they didn't read a label properly. It could be fatigue. It could be a distraction. The best people make mistakes.
When an error happened, every one of us who is directly or indirectly involved, we don't feel good about it.
I can remember that event like it was yesterday.
It made me feel horrible.
I really almost killed someone.
I know exactly the pain, the shame, the embarrassment that I felt.
Well, I hate myself.
I thought I was frightened, scared for my life.
It was transformational for me in many ways and crystallized my own passion for safety.
We can no longer turn a blind eye to some of the safety issues that are happening within our hospitals.
And why now is because I don't think it's getting better.
And there's no question that errors can be prevented.
UHN has the opportunity to lead in this regard.
We don't want our patients nor our staff to be harmed by preventable errors.
Caring safely means being able to prevent harm.
It means embracing safety as a core value in our organization.
Where all our staff feel that they are all safety leaders.
Wanting to provide a safe environment for myself as well as my co-workers.
Without healthy working staff, we can't have healthy patients.
Because ultimately, if it's bad for the patient, it's really bad for our staff.
There's certain never events that really shouldn't occur in hospitals that we can actually prevent.
But there are going to be things that happen that maybe we haven't identified.
We have to state a goal of 0 safety events, getting to 0.
And we wouldn't be doing our patients justice if we were okay with some incidents happening.
We can see from the experience of other organizations that this type of goal is achievable.
And there are hospitals that have turned the tide and actually decreased their serious safety events.
The objective is when staff member A makes a mistake, how do we build in a redundancy? How do we build in a safety net so when that error happens, either your peer catches it or we have support system that alerts the staff that something wrong is going on?
Every time a human makes a mistake, we need to look at what was it they were doing and was there a system issue involved that we can correct or mitigate happening again.
And fixing them for the long term.
We need to recognize that many errors inside medicine today occur as a result of communication gaps and as a result of cultural things such as fear of reporting.
Caring safely means that we have to change the culture that we were brought up in,
which is described by many people as shame and blame.
Then we need an environment where when that person notices something, they feel empowered to actually question that and to raise that as a concern. And then the response to that is, thank you very much.
It's about focusing on what we could do better, not who did what wrong.
Because when you speak up, what you're trying to do is prevent that person from making an error.
When it comes to safety, there's no room for ego. It's all about the patient.
Success is very much where people have a comfortable environment that issues can be brought to the fore.
The trick is not to do it again. The trick is to actually learn from it and not keep it to yourself, but share it with others so that somebody else doesn't make the same mistake.
We should reward people who report incidents.
If somebody raises a safety issue in one of the huddles, we recognize them often with a good catch letter.
We want to keep our co-workers safe. We want to keep everybody working in all the capacities in the hospital safe.
We want to ensure that our patients and our staff are safe every day.
We all have the power to make a difference.
Be part of the solutions.
And help us design a better environment for caring for patients.
We're committed to caring safely because it's the right thing to do.
It's time to act.
You're responsible for people's lives.
Caring safely is with us and it will be with UHN forever.
These are our references. And thank you very much for listening.
Okay, thank you so much, Dr. Ronald Chakova. It's so important to understand these topics in medication safety, especially as Africa, that part of pharmacovigilance, looking at drug-related issues, is a bit silent. It's not very prominent in terms of legal infrastructure, in terms of many issues. So I think it's a good place to start to reflect on these issues from your presentation. So I'd like to invite you to please continue writing your questions in the chat pod on the left. And I would now like to start with the questions to the presenters. The first question is that do you have any experience, this is to Dr. Lubna, regarding the administration of different vaccines in the same person? For example, if someone got Pfizer and then got Sinovac. Lubna?
Dr. Lubna, could you please open your mic?
Thank you, Angela. Thank you, Helen, for your question. So regarding this situation, we had some errors for in our patients. So they didn't present any adverse drug reaction. However, there are not currently any clinical data of the efficacy of mixing up the vaccines. So it is recommended to have the same vaccine in the first and in the second dose. And if we have this situation, we should consider that the patient is vaccinated, it's fully vaccinated. So this is what I can say about this situation. The efficacy, I think that studies should be conducted to do this mix-up and find if there is efficacy or not.
Okay, thank you.
Welcome.
And maybe the other question is, someone had a question that my mother had the first dose of the AstraZeneca vaccine, and then she's obese and has diabetes, and she took medication she's taking medication of metformin with vidagliptin, and that is for type 2 diabetes. After having the vaccine, she had a high rise in D-dimer of 5,000 and more, and then they started Xarelto, and the D-dimer decreased. We don't know what to do for this section. What to do for the second dose. The doctors were proposing that wait for 6 months and do the analysis for the antibodies in the blood, and then try again to do the second dose of Pfizer, to do 2 doses of Pfizer. Do you have any advice for me? Thank you. That is the question.
Thank you, Ellen. So regarding this case, I don't know if they did the PCR for these patients. Maybe it was the COVID-19. She had a COVID-19 after the first dose. It could be because COVID-19 disease could led to D-dimer increase. So otherwise, when we had such situation with thrombosis, in Morocco, we recommended to give the second dose when the patient is is equilibrated, and there is no no problem with his diabetes, for example, for this patient, and so on. So, and this is what I can say regarding this situation, because I don't have all the information about this case. So the case should be discussed with the physician and the pharmacovigilance center. But in our case, even if there is some thrombosis after the vaccine, our healthcare professionals, our experts in hematology, they recommend to have the second dose.
Okay, thank you very much, Lubna. Of course, most of the time we have program errors as part of the immunization errors. That's the highest usually event reported. So there's a question from Brazil, that in Brazil, the second dose of Comirnaty, that is Pfizer, is administered after 3 months from the first dose. Is this good? Could it interfere with its effectiveness? Is 3 months okay?
Yes, 3 months. I think it's too long. 3 months. They are now currently in the clinical trials. The efficacy of the vaccine was made according to the intervals that recommend in the SPC. So if you use it beyond the intervals that are recommended, the efficacy, we could not have an idea about the efficacy. Maybe further studies could be done in Brazil. They should maybe conduct a study according to the intervals that they are using, and then make some laboratory tests about the anticorps, and to know if there is efficacy or not. But in the clinical trials, there is no clinical data about the efficacy when you use the vaccine beyond the dates that are the intervals that are recommended.
Okay. And there's another question that comes in. I think this is to deal with the process of pharmacovigilance. It says, at what point are the adverse events following immunization classified into the different types of adverse events? Is it immunization error-related reactions in this case? And is this done automatically by the national database, or is it done retrospectively by the researchers?
So in our experience, our healthcare professionals that report adverse drug reaction, they reported them through our pharmacovigilance relays. So our pharmacovigilance relays were trained and well trained about immunization, adverse events flow in immunization, their classification, and they know about that. So regarding immunization errors, they were reported as immunization errors by the reporter, okay? Regarding the serious adverse drug reaction, we, for these cases, because they are serious, we did a follow-up and of these cases, so to know if if it's related to the event, if it is related to the vaccine or not. Okay, so in these cases, we did it was done by the Pharmacovigilance Center, and it was done day to day, according to the information that you have about the case. But regarding the other frequent adverse events following immunization that are known in the SPC, such as fever, chills, we mainly related them to the vaccine. But the serious one, it was done by that. And for this, the frequent, it was done retrospectively. And when we check our cases in VigiFlow, in order to validate them, because they are sent by our pharmacovigilance relays, So they sent us, as the National Pharmacovigilance Center, all their cases, and we validate them in order to send them to Vigibase. So when we do this validation, we make some, we do the causality assessment, then to know which one. So, but we really work very, very hard on those that are serious, because we need to know if it's related or not. Mainly when we have some thrombosis, so we need to have to do all the investigation to know if it's related or not, because the vaccine is, when there is a serious case, we should, if it's a signal, we should report this to the national level and maybe for decision makers. So these cases were, we focused on more, and then the other that were AFIs that were in the SPC before, and were detected in the clinical trials.
Okay, and then maybe the fact that someone mentioned D-dimer, it reminded me about a question of vaccine adverse events of special interest. Did you, what is your experience with those? Did you have any?
Yes, we did. We as you say, that these adverse events of special interest, many of them in Morocco was regard thrombosis. And when we do the investigation, when we do the causality assessment, we find that the majority of them had an underlying causes that could be responsible of this thrombosis. So we work on them with experts on thrombosis, with the physician, with the patient, and we have discussion, and many of them were not related to the vaccine. And we say that it was coincidental, adverse event following immunization.
Okay. Okay, thank you for that. Well, I think there's a lot of interest in your presentation. More questions are coming. One of them is saying that in your experience, what are the biggest challenges, what will happen if someone got a vaccine when they are symptomatic of COVID? And if the problem happens, how should it be controlled?
So if I well understand, he had the COVID-19 disease after the first dose. This is
yes, like the question which was earlier, and you said, did they do a PCR test? So if they found that they were positive, what would what would you advise them if they're already symptomatic of COVID, and if the problem happens, how should it be controlled that someone has been vaccinated when they have COVID?
We didn't have such a situation, because, but it could happen. So maybe I think that the second dose should be postponed after the patient gets well. And at least we recommend in Morocco 4 weeks after they get well, and after the 4 weeks after the apparition of the first symptoms, and they should be asymptomatic and have good to be good in to have disparition of all the symptoms. So this is what we recommend if we have COVID-19 after vaccination. So if it's in the same day, I think it would be the same recommendation. I don't know. We didn't have this situation in Morocco, but maybe it would be that. I'm not sure. So, but what we recommend in Morocco is 4 weeks after the apparition of the symptoms, but if the patient is getting well and disparition of all the symptoms that he had.
Okay, I think that is it. And as you may know, we are live streaming on Facebook. So there's a question that has come in from Facebook that once COVID vaccine booster is allowed and provided that almost everyone already completed the vaccination, is it safe to switch to another brand?
I don't have an idea about that. So, but if he had the, I think if he has the full vaccination, the first and the second dose, he should maybe give the opportunity to another person to have the vaccine and not to take another vaccine, because we have the problem of to have the vaccines in our countries. So we should give the opportunity for others to be vaccinated.
Yes, I think you're right there. And then maybe also back to your study. I just wanted to ask how was the perception of the healthcare professionals in charge of the vaccination process related to the medication error prevention recommendations that you made?
They were very, very happy about that, because the trainings were done before they begin the vaccination sessions. So it helped them to prevent immunization errors. They helped them to organize the workflow in their sessions. So, and also when an error happened, they report to us. They were sensitized to reports to the pharmacovigilance center if the error happened, in order to have risk minimization actions. So they adhere to this reporting of immunization errors, and their concern was, when they report, was to know what to do about this immunization error, and how to what advices to give to the patients about this if the error happened, and how to communicate with him, and if there are any risks regarding this immunization error. And they help us to understand why the immunization error occurred, in order to improve the workflow, to improve the organization of the immunization sessions.
Okay, thank you. And I would like to move on to the next presentation, discussion of the next presentation, but I also see a question from one of the participants called Isabel V. Would you please unmute yourself and make your comment, if it's in line with Lubna's presentation? Yes, Isabel, please go ahead.
Isabel, could you please open your mic?
Well, maybe then we'll move on to the next presentation, Dr. Ronald's presentation. One of the questions is, how can employee perception of the management commitment influence patient safety?
Thank you very much, Helen. I think it is important for leaders to lead by example. So, for instance, if they are trying to promote an agenda where systems do not seem to suggest even the slightest evidence that management has set in place systems to improve on the delivery of care in terms of promoting the safe culture, then I think the employees will listen to management, but will always take the message with a pinch of salt. So in my view, most of the errors that occur in healthcare are system related. And you can see from what Dr. Lubna presented that, they identified that the majority of the errors were actually resulting from the system. So if the system is the biggest risk, then we have to start with the system, and that's where management has a key role to play.
Okay, so in that light, so do you think that the medication safety officer then should be a part of the management of the institution that they work?
So first and foremost, by setting aside a specific role, which is the role of the medication safety officer, is a huge statement by management, especially if it is a role that they support. And in my view, then the medication safety officer should be afforded a seat on the management committee, because safety is key. If you look at the airline industry, safety is paramount. Mistakes may rarely happen, but when one occurs, it's usually fatal for many. So you can see that in that industry, safety is taken to be priority one. So if the medication safety officer is given an opportunity to sit on the management team, then they will be able to feed information to top management in real time, so that actions are taken in time to prevent harm which would have involved many. So if the errors and the issues that bring about unsafe culture are addressed as fast that management can, then I think that the role of the MSO will have been felt. Yes, and I believe they should be up there in top management. Thank you.
Okay, and then maybe the other thing is, I mentioned briefly about the legal framework about medication safety officers. What do you think? Should it be there, or do you think that the current systems, especially for low and middle income countries, what would you recommend? And especially also around the issue of building the system or the team, the people to work with the medication safety officer. Who should be a part of that team? What recommendations would you make for especially low and middle income countries, where you said in your presentation that most of the times the officers are overwhelmed, the current healthcare professionals? So establishing a new role, maybe even with the curriculum from the university, about medication safety officers. What are your recommendations in that regard?
Thank you very much. First of all, this is a relatively new field, but with an old concept. So I think that we need to have a system in place that prepares this new role during pre-service training. We already have the PSOs, the patient safety officers, but that is broad. It can be occupied by any cadre. But for the medication safety officer, we prefer someone who has already received background training in healthcare. It could be a nurse, it could be a medical doctor, it could be a pharmacist. And so we feel that this course ideally should train existing health workers. And so it builds on what they already know, what they already have, and then puts them on in the next level with a higher IQ, focusing on patient safety. And so we believe that when this role is set aside, then we begin to think about the team that they should have in place. So we talked about the legal system. You know, people don't want to report because they fear litigation. So there needs to be a system that basically advises the healthcare system, the healthcare providers. And then we need to have others on board we need, for instance, if you imagine a patient who has been admitted on day 1 as an inpatient, and until day 5, they have not yet received the first dose of any prescribed medication. So you can imagine what happens. So there's prescription, there's transcription, there's all these processes. So, and there are individuals that are involved at each of these levels. So you want to make sure that the medication safety officer has the interpersonal skills, the ability to interact with all these other persons. So they need to build a team, beginning with where they are, because health facilities differ in their structure. Some are complex, others are less complex. So it's a role that will evolve with time based on how it is received in low and middle income countries.
Okay, maybe then you would give us suggestions of how, maybe strategies to see that this can be well received. I don't know if you would have any recommendations in that guideline already, of course, because it means the resource envelope is being affected. So maybe you'd give us some recommendations.
Like I mentioned earlier, pharmacists have traditionally played the role of monitoring patient safety, and in particular medication safety. So it could be a starting point. So for instance, during the ward rounds, could have the pharmacist participate. During the dispensing of medicines, this same pharmacist, who could ideally be on the already established employment system, can actually play this additional role. So, and by doing so, you're trying to demonstrate, you're arguing a case for the medication safety officer. If such facilities can then demonstrate that this pharmacist has actually helped the hospital to significantly reduce the occurrence of medication errors and the resultant harm, then I think at that point it would be a good opportunity to advocate for a separate role for someone who will focus on ensuring that healthcare is delivered in a safe way. And we could start with the huge hospitals, the regional referral hospitals, and the national referral hospitals. And with a fair demonstration of how useful these officers are, it could then begin to trickle down. But overall, I should say that it should start, and you can start from where we are. If our worry is the resource envelope, let's begin with what we have. It could be a pharmacist intern, it could be an MO intern, it could be a nurse intern. And these usually have the enthusiasm to support this system.
Okay, thank you. Actually, I see maybe in terms of the academics, I see modeling and using models to demonstrate the cost reduction to convince health policymakers to do something about it. So there is hope. So there is a question that that says that, in your experience, what are the biggest challenges affecting medication, adequate medication error reporting?
Thank you very much. Like I mentioned earlier, the biggest challenge is fear of being reprimanded. So the health worker or any other person in the healthcare sector would not want to be associated with errors, so they would rather not report, and that's a huge setback to any medication error reporting system. Ideally, the health facility can then work on. Remember, I talked about the legal advisory system. So, if they could encourage the health workers to report without, basically with the protection, that the reporting is to help improve our learning and ultimately the safety of healthcare. Then that challenge could be overcome. Secondly, the safe culture or safety culture in low and middle income countries is still wanting, and yet it's a foundation. We need to build a safety culture. Once we have that in place, then we can begin to get onto our pedestal towards safer healthcare. Then the third issue is the systems. So systems is still a challenge in many low and middle income countries. So, and by systems, it's a broad term, but it's as simple as knowing that there is a structure, for instance, for knowing how to deal with errors, rather than think about, who caused the error and therefore blame that person. The approach you'd want to see is, okay, so the system is interested in learning what caused these errors. So you have in place that sort of flow of information. Most of the errors that have been reported have occurred during shift changes. So that definitely means that that's a system-related issue. So systems in our part of the world are challenged. And so even the reporting, if we talk about the use of technology, if technology is embraced, technology is one aspect that can help promote the reduction of medication errors. Thank you.
Okay, and maybe I would also like to ask, you talked about the key performance indicators, and these key performance indicators, you mentioned the issue of measuring how many adverse events. Of course, in terms of pharmacovigilance, that would be like the negative system, but in terms of your assessment, I saw that you were saying that it is mainly to reward the reporters. I don't know what you would like to comment about that. And also in terms of the key performance indicators, we already have what we call medicines and therapeutic committees. Do you see a role of these committees in the area of medication, in supporting the medication safety officers?
So thank you very much. So health facilities can build quality improvement systems. So by quality improvement systems, you are thinking about measuring how the hospital is performing in terms of set measures. So you measure at intervals to see if there's any improvement in key aspects. So when you have that system in place, you then want to have interventions that will promote safer healthcare. And therefore, if you can think about reward systems, you might want to reward those who report more. You might also want to reward hospitals that are promoting the reporting. So this has been, for instance, practiced in countries like Canada, where the actual reward hospitals that perform well. And sometimes when you're renewing a license, or if, for instance, a health facility or healthcare professional is renewing the license, this can contribute to the credits that you need in order to renew your licenses. So we should have in place interventions, not complicated ones. Many times these are simple things that that actually reward the health worker. We know for a fact that most of these errors are system related. So top management needs to sort out the equipment, sort out the flow of information, sort out the what they feel should ideally be in place during healthcare delivery. And then the individuals, the health workers, will basically fit in, and with the motivation that they need, will actually deliver safer healthcare, and will be in a position to report, to learn, and report to improve. Thank you.
Yeah, I haven't seen any other. Okay, there is a question that how about the cadres who administer medicines, the nurses? These may be better compared to pharmacists. And then maybe I'll also give you the last one. In your experience, what could be the major indicators that should be monitored with quality improvement?
Thank you very much. I think one of the easiest indicators is to do serial surveys, which I mentioned earlier, when you have a quality improvement system. So you measure the rate of occurrence of medication errors. That is easy to measure. And then you do it maybe after 6 months, and then you maintain that sort of interval. And then you're able to check whether the rate of medication error occurrence is going down, for instance. So that's one approach which I presume can readily be implemented in low and middle income countries.
Thank you very much, Ronald. And I think there are no more questions. I think the hand that is there was already addressed. So would really like to thank you. It was a great conversation. Thank you so much for the answers that you have both given and for your participation in our session today. So the next presentation will be from Europe, and it will start at 4 p.m. UK time, like in another 12 minutes. So we have other speakers and topics. Please feel free to join in, and please remember, if you want to refer to this webinar again, it will be available on our website or any other webinar of this Patient Safety Day. Please go to the ISoP Online Facebook account or in our YouTube channel. We'll publish the recordings there of this event in the coming days. And would like to really thank you so much for participating in this. And well, thank you on behalf of the International Society of Pharmacovigilance, especially the Africa chapter. We thank you so much for your participation today. Have a great day. Thank you.
Thank you. Thank you, Helen. Thank you, Ronald.